Well, thank you very much for allowing me to present to you today the practical aspects of re-irradiation spine SBRT. My name is Arjun Sahgal. I'm a radiation oncologist at the University of Toronto, Sunnybrook Health Sciences Center. Just my disclosures. So let's first talk about conventional palliative retreatment external beam radiotherapy. And what is the efficacy? If somebody has failed conventional radiation, does it make sense to give a second and even lower dose of radiation for the fear of causing radiation myelopathy or other toxicities due to the cumulative dose in the wide fields? Well, there is a randomized study that was led by Edward Chow here at Sunnybrook, and a Canadian study that looked at re-irradiation with conventional typical fractionation schemes of 8 gray in 1 or 20 gray in 5 or 8 fractions. And basically what we see is that there is some response, either in the intent to treat analysis or per protocol analysis, but the complete response rates are really quite low. And if you look at it, we're talking about 10%. And that's really no different than we get with the upfront radiation with conventional radiotherapy. So again, there's some response. We're helping a little bit, but not doing a very good job. And this was a large randomized study. So then comes stereotactic body radiotherapy. And one of the initial indications was actually for re-irradiation to overcome this issue of lack of efficacy when somebody failed conventional external beam. So one of the first experiences out there was actually done at University of California, San Francisco when I was a fellow, and I looked at our previous radiation experience where patients were either treated with SBRT to salvage conventional radiotherapy failures, and then also the upfront radiation cohort. And what we actually observed was similar efficacy in terms of local control, and we did have some pain data, but not really good quality. We were able to control that it's effective treatment, able to induce local control as compared to de novo situation. And we put our data when I came back to Toronto in a multi-institutional database, and we actually showed, again, very good local control rates, about 80% at 1 year when treating with re-irradiation SBRT. And again, these are patients who failed previous conventional radiation. So overcoming potentially that radiation resistance and why they failed conventional radiotherapy. So there is some data for pain response, and it really comes from Henry Ford. And they looked at their re-irradiation efficacy. Again, it was retrospective, not high quality data, but they did show complete response rates for pain of about 18%, complete partial response rate of about 63%, and a good palliative outcomes. And again, these are some good data, low toxicity, but actually have a little bit of pain data, as everything that we had was really focused on local control. And there was a recent article from Japan, again showing high rates of pain response in patients treated with re-irradiation SBRT. And the median pain failure-free duration was 13 months, and 1 year pain failure-free rate, 55%. So this is supporting very high rates of efficacy that are durable over time. But again, we really don't have a lot of good quality data. Now, if you look at my most recent experience where we looked again at local control, because we're not necessarily collecting high quality pain data as we have in the de novo situation, we are seeing, again, very high rates of local control, about 80%. But it isn't for everybody. And there are some patients with brain mets, neurologic deficits, certain histologies that are radioresistant and near the end of their trajectory of metastatic disease, where we see really quite kind of poor survival rates, which may not support such a resource-intensive technique. But there are some patients that are going to benefit. And these are patients who had conventional radiation, some had a previous SBRT, and we were able to effectively salvage them with spine SBRT. And I typically give 2 fraction or 4 fraction stereotactic radiation. And that comes to the common doses. And in re-irradiation, we don't really use doses like 24 and 1. There's not a lot of single fraction data, although there are centers that do use 18 gray in 1 for re-irradiation, but most centers actually fractionate. So I use 24 gray in 2, some use 3 fraction, 4 fraction. 5 fraction is very common, 30 gray in 5 fractions. And these are kind of more common re-irradiation doses. Now, you can prescribe what you want, but at the end of the day, it's what you limit your spinal cord PRV or thecal sac to. And the data that suggested safe tolerances really came from some work I did many years ago that establishes the lower end of the bench line in terms of tolerance to the critical neural structures despite previous radiation. And there really hasn't been any further data, but I can tell you for about 5 years, I've increased these numbers by about 20% and they're safe. So I would say the original publication is the conservative estimate. You shouldn't go below it. And I've increased these numbers by 20% and it's gone good. And again, I give mainly 2 or 4 fractions. So 24 and 2 or 30 and 4. Now the technique, regardless, de novo, re-irradiation, it's the same. The principles are the same. You need to near rigid bodily immobilize, thin slice CT, thin slice MR, use sub-centimeter MLC, cone beam CT, 6 degree of freedom correction for your Linac, or if you're using a cyberknife, then the cyberknife corrects itself with the robotic head. Otherwise, we're mainly just talking about couch correction thresholds. So ultimately, our technique, applying all the bells and whistles, has shown a 95% confidence in trifraction motion of 1.2 millimeters and 1 degree. And that really leads to our PRV margin of 1.5 millimeters and our PTV margin of 2 millimeters. And again, our experience has been safe and robust. Now, contouring principles in re-irradiation, doesn't matter de novo or not, you're still not treating the GTV. None of us do it like that. We all apply CTV because you can't really know on an MRI where that GTV is. We still do not have the sensitivity and specificity like we do in the brain of knowing exactly where the GTV is. And so we don't necessarily have the confidence to exclude anatomy at risk. And again, the experience has been safe. Now, one of the issues I do talk about, and particularly in the re-irradiation scenarios, many times that's the last time you can give radiation. You certainly want to make sure you have enough margin. And I talk about the craniocaudal margin, paraspinal disease margin, and we apply at least a 5 millimeter margin around paraspinal disease extension, respecting anatomic barriers, but also in the craniocaudal. And when I talk about the craniocaudal, I'm talking about giving an extension along the canal so that we don't have marginal failures epidurally. And we really track on the sagittal image that epidural extension and make sure we're at least 5 millimeters above any potential microscopic disease. Now, in the sacrum, it's different. So we have had some sacral guidelines. And again, I've been following these for some time. We published our data and it's been safe. The principle is taking, again, the anatomy at risk. Some people take the GTV alone, but we've been taking the anatomy at risk in the sacrum. And you can really look at the compartments and follow the embryological lines to determine where those thresholds are and use those fusion plates analogous to a disc to know where S1, S2, S3, S4, S5 are, and then your ALA based on anatomy. And again, these are good guidelines that we've done as an international group. I published our outcomes based on these data, and we've seen good responses. Now, post-operative, just again, very practical. You may see a lot of patients, where patients have failed conventional radiation, had surgery, and now what do you do? Do you give them a low dose again of radiation, or do you give post-op SBRT? And post-op SBRT makes sense because you just put them through a big operation. You want to induce local control. And these guidelines should help you in terms of how to draw the CTV, because it is really quite challenging post-operative SBRT. And you really have to get good at it, understand it, and also understand your outcomes. Now, spinal cord contouring in spine SBRT is a major issue because it is difficult, and there's hardware in there, and that can sometimes warp or distort the imaging. But with good T1, T2 imaging, I really have not had a situation where I've needed a myelogram for several years. There are some situations where we do need a myelogram, but more often than not, you can do it. And even with a myelogram, once you apply your MRI, you have that certainty of where the cord is. But there are some situations, as you can see below, there's a lot of artifact. You're at a cervical thoracic junction, you're acquiring axial images, sometimes on the same plane, on the same image, seeing two cords. and it's just impossible to do. And even with a myelogram, sometimes the artifact is just too significant. So there are ways to do this, and myelogram is a powerful tool, but it may not necessarily always solve your problem. And again, with good T1, T2 volumetric imaging, it tends to be okay. Now, plan evaluation is really something that is a more of a challenge in re-irradiation, because you're limiting your critical neural structure to an even lower dose. So you're not going to get that 90% coverage of your CTV or PTV. You're going to have to accept a drop down in terms of 80% necessarily coverage. And it really is whatever you set your cord, PRV, or thecal sac dose limit to. And these are some examples of plan evaluation situations whereby you can see in the top situation, we really want to try and bend that isodose line and cover our PTV that's adjacent to the cord PRV. So it does mean over-treating normal anatomy, but it keeps that gradient really sharp. And you can see by bending it here on the right, you're really keeping that gradient sharp along where, in this case, there's epidural disease. And in the bottom compartment, it's about maintaining that gradient as sharp as you can. Sometimes it can get a bit loose. You push it so that you get these nice concentric rings around your critical neural structure. And that's where the planning comes in, which can be, again, really quite challenging. But in this situation, which is a typical SC24 plan, whereby we use 17 gray to the core PRV, which is our older dose constraint, we can get a PTV coverage of about 80%, CTV coverage 85%. And it's because you have epidural disease here, your PTV is adjacent to the cord, your CTV is adjacent to the cord, you have to accept some under coverage, and your cord PRV thecal sac dictates your coverage. Now, re-irradiation is even more challenging. So in this situation, we limited the thecal sac to 12.2, which is, again, my older numbers. And you can see here in the top, you're really splaying those isodose lines out. And we want to bend those ears in, try and maximize our coverage in a situation where we're going to have to compromise anyway. So if you see that kind of splaying out of the isodose lines, bend them in, over-treat those pedicles, but get the conformality of the dose distribution, you'll get better coverage. And you have to accept things like 90% coverage to the CTV, depending on what your dose limit is. So you don't necessarily get these high PTV coverage rates. And again, here the PTV coverage is around 87%. With new numbers, that those will go up, and with our established protocol in the de novo situation, you're typically talking about 90% coverage, but you're going to have to sacrifice some re-irradiation. Now, there are ISRS practice guidelines out there that do recommend spine SBRT as a re-irradiation technique. Again, there's not a lot of data. We need some high-level evidence, but there are some patients where you have to use your judgment that these are patients that are going to benefit, they're going to live. Let's give them something more efficacious in terms of local control. Now, this issue of epidural disease and coverage is a major one. And you can see that we had to compromise on coverage as a result of epidural disease because there's not enough space between the tumor and the cord in order to maximize coverage. And it is what it is. If the tumor is coming to the cord, you don't overdose the cord, you just accept less coverage. But the motion or the field is moving in such a way that we're doing more for those patients. So in selected patients, do techniques that can resect the epidural disease. Don't necessarily do the vertebrectomy and go ahead and then treat once you maximize that distance between the cord and the disease. And this is the concept of what we call separation surgery. And here, these have been tend to be big open operations, but the goal is not necessarily vertebrectomy, but it's about decompression and stabilization, and use the spine SBRT to maximize control, because you don't necessarily need the surgery to accomplish that goal. Now, instead of these big open operations, we've been trying more minimally invasive techniques like day surgeries or tubular retraction surgeries, where you can really kind of achieve that goal of decompression, put some cement in there. And as some patients don't need instrumentation. But even with instrumentation, this can be done percutaneously and still do your tubular retraction decompression. Now, just in terms of dosimetry, there's no surprise. I mean, the physics are there. If you maximally regress your epidural disease and increase your separation, and we did this exercise looking at a stepwise reduction of epidural disease up to 6 millimeters, your minimum dose and your D95s and D90, D98s all increase. But there is a three-dimensional anatomy to this. You can't look at one slice and say, I'm going to get a 10% increase, because it's all kind of three-dimensional and linear. And there's some patients where a lot of surgery is needed to achieve a lot of gain in terms of your BD95, but there are others that don't need that much surgery. And it all depends on that anatomy of the epidural disease and what's happening and how it's encircling or pushing the cord, as it is a very complex phenomenon. So the surgeons really have to work in terms of understanding the entire length of epidural disease and how they want to approach their maximal decompression. So why do we want to do so much work on epidural disease? Well, one aspect is the dosimetry, but the other aspect is that it's biologically aggressive disease. And the most common pattern of failure, whether it's post-op or de novo or retreat, is always epidural disease failure. And this is a situation where we did surgery. We treated with spine SBRT, and lo and behold, you see 12 months later, epidural disease failure. And this is the problem, because what do we do now? We're not going to do another surgery. How do we maximize our approach to re-irradiation in this scenario? Because in this situation, no surgeon would ever go back in, but this is the most common pattern of failure. Although the failures are about 10 to 20%, when they happen, it's very challenging. And this is where we talk about spine SBRT failures. And one of the aspects is making sure that we diagnose them correctly. So there are various patterns of failure. I showed an isolated epidural disease failure. This is a failure rate in terms of diffuse progression. So here, there's some signal change, a little bit epidural disease thickening, and lo and behold, goes on to have full circumferential epidural disease, T1 darkening of the entire vertebra. And this is clearly kind of overall disease progression. But this was really challenging in the beginning to understand, because we still don't understand a lot about signal change in MRI over time with high doses. We see darkening, we're not sure sometime, and we continue to follow. This is an example of one of the challenges where we treated this patient, spine SBRT. We saw regression of the disease. See, the epidural disease is kind of regressed, but a lot of the signal change on the T2 image, we weren't sure what was going on, but the epidural disease responded, and lo and behold, things started to progress and the epidural disease started to come back. And it became much more clear that this was a failure. But there is the phenomenon of pseudo-progression, just like in many sites in terms of SBRT, whereby we do see these increased signal changes in the tumor volume on MRI, and then they slowly regress over time. And it's really hard to diagnose this, especially in cancer, because there's so many things going on. People are getting chemo, they're getting other things. So we wanted a very clean data set of sclerotic metastases like prostate cancer and hemolytic, tumorish type of tumors like in RCC. And we saw that pseudoprogression tends to happen more in RCC. And there's some clear phenomena where you can start to see clear progression. But the incidence of pseudoprogression in our series was 37%. Again, these are very clear data in the sense that they didn't have any further treatment, no chemo, no radiation. We could isolate, we could follow the imaging. They all had multiple images over time. And we think the incidence is around 37%, which is not so far from the brain. Now, we talk about local control, and we need some criteria. And it's not so clear what it is. You can't use RECIST or a linear dimension. So we basically came up with some criteria. And we said, look, a gross unequivocal increase in tumor volume or linear dimension, new or progressive epidural disease, neurologic deterioration. When things look a little bit worse, is probably progression. And we're doing some work that's coming out, actually looking at dimensions now that can help us predict who's a failure based on some changes. But again, it's very early. At the end of the day, where the challenge lies is once you do know you have progression, like in this case where it was treated, this was a sarcoma patient, had a clear progression after spine SBRT, what do you do? And the issue of spine SBRT failures is going to become more challenging. And what we saw actually is that we can re-irradiate with a second course of SBRT, just fractionate it more. So instead of 2 fractions in the beginning, I give 4 fractions, and you can induce response. And in this very well-selected series of repeat spine SBRT, we did see good local control. The majority had very low-grade epidural disease, and we were successful. And we didn't cause harm in terms of devastating toxicities. The majority of patients were treated with 4 fractions, but you can see also the survival rates are dropping quickly because these tend to be very sick patients. Now, we did give you our cumulative doses and how we dosed the salvage SBRT course. And there was a cohort of 24 patients in this series that had external beam, SBRT, and then I gave the 3rd time. So you can get the cumulatives, you can see what we gave, and it can help guide your practice. But again, use those very conservative dose limits on the re-irradiation guideline for spinal cord tolerance. And that's usually what I do, and I follow the table. So let's talk about late toxicities, because I think this is important, and it's the area that we have to pay attention to, re-irradiation or not. But in late toxicities, we still see fractures, and fractures can be very important in terms of the pain and suffering a patient can endure at the end of life. And again, with re-irradiation, they tend to be more at the end of life stage. So we did some work. We saw that patients with baseline fracture, malalignment, lytic tumor, and treated with very high doses are going to be at an increased risk of fracture. This is work in the de novo situation. And we showed that doses like 24 and 1 can really increase your risk of fracture. And what we do is 12 gray times 2 really reduces that risk of fracture. And there are some data that say re-irradiation increases the risk. Others state it actually decreases the risk, possibly because we're selecting patients better. But there's no clear evidence that prior radiation causes this major increase that we would not otherwise see. What you do have to understand is the risk is there. And by increasing the fractionation, you increase the safety, and that may be a consideration for re-irradiation. Now, fractures can happen acutely or as a result of acute inflammation, destabilizing the vertebra, or in the late phase. And these late fractures are really that smoldering necrosis, the bone starts to crumble, and you get fracture. Now, one of the other areas that are actually really important in terms of nerve root, in terms of re-irradiation is nerve root toxicity. And you do have the brachial plexus and you have the lumbar sacral plexus. Otherwise, we don't really pick up or know about radiculopathy. And the lumbar sacral plexus is interesting because you have long lengths of nerve roots being irradiated. And there may be a length effect in the peripheral nerves that are not seen in the spinal cord. So we looked at our outcomes. And we said, what are the main toxicities that we have to be conversant about in patients who are going to live a long time? So we looked at our series. First of all, we want to see, were we selecting patients well? So who died within 3 months, because those patients shouldn't have gotten spine SBRT. And then who's living more than 3 years? So it was an interesting study for us. We looked at our database of 600 patients treated, 1,400 spinal segments treated with spine SBRT, and we found that the minority were really surviving less than 3 months. And these were really poor performance status patients. So only 52 out of the 600 died within 3 months of SBRT, but 79 lived more than 3 years. So the majority are in the middle. And there are that cohort that are actually going to live a long period of time. It's probably going to increase over time as we use more targeted therapy and immunotherapies. So we have to be mindful of those late toxicities. Now, what you see here is the fracture risk goes to about 10%, just like we've observed. Over time, it starts to creep up a little bit more, probably that late radiation necrosis that smolders through. But we start to see this plexopathy. And this plexopathy in our series happened mainly in the lumbar sacral plexus and in patients who were re-irradiated. And that's why I spend a lot of time talking about re-irradiation, lumbar sacral plexopathy, particularly when we're treating lumbar sacral segments, because it is a devastating toxicity. It's not like myelopathy or cauda equina necrosis, which is paralysis, loss of bladder bowel. This is an insidious pain, neuropathy, and it can really affect patients and really impact their quality of life. And it's really quite difficult to help patients because there is really no treatment. So in the re-irradiation SBRT, I think you have to be very careful. Otherwise, it's still rare, under 5% risk. So in conclusion, I would say that re-irradiation spine SBRT is an emerging field with great promise for patient care. It's very powerful as a treatment for conventional external beam failures. It can also salvage in-field spine SBRT failures. Now, radiation myelopathy is really not as much of an issue as compared to vertebral compression fracture, and we're getting an increasing understanding of plexopathy. We do need high-level evidence for re-irradiation, as it's currently really quite limited to low-level retrospective reviews and few prospective studies. We do need randomized studies like we did in the de novo SC24 trial, where we proved that spine SBRT can induce higher rates of complete response for pain as compared to conventional radiation. And that was the randomized study that we did in de novo patients. We would love to do that in re-irradiation, and we do have a re-irradiation conventional study that really shows poor efficacy. But these are hard studies to do, and this patient population is rare. But similar to brain radiosurgery, where we salvage after whole brain failures, spine SBRT is a salvage for conventional failures. It'll move more and more to the de novo situation, but don't discount it and use it in a legitimate way for patients who you think are going to survive a long period of time and failed conventional radiotherapy, because you can really help them and induce long-term local control. So I just wanted to kind of end with a fellowship program. We have had fellows from India, and Archaya Dasgupta was with me for some time, and we would love to have more fellows from India come and join us. And we do have an intake, and Hani Solomon is our fellowship director, along with now Irene Karam. So we're happy to provide you any information that you need. And we do have a new second edition that came out, really going over image-guided hypofractionated radiosurgery for brain and spinal metastases. We have a dedicated 24 grain 2 fraction chapter, but we have a lot of important information for hypofractionation. And with that, I say thank you very much for this invitation, and I wish you all the best in this conference.